The readings for this week outline a couple of different theories of health inequality that I want to make sure I take the opportunity to go over. These theories are discussed both in the text, chapter 3 of the textbook, and also in the article that you read by Lincoln Phelan. Essentially, what these theories are doing is they are explaining the relationship between health and social class. What they're doing is answering the question of why people at the lower end of the socioeconomic ladder are more likely than people higher on that ladder to be ill. So there are 3 theories that are discussed in this week's material. The first is the social drift hypothesis. Second is fundamental cause theory. And third is cumulative inequality theory. So we're going to walk through each of these so that you get a sense of what they're all offering as an explanation for this relationship and how they differ from one another. So first, I think it's helpful to visualize what each of these theories is really saying in terms of what is the cause and what is the effect. So if you focus on the top part of this picture, the arrow that's moving from social class to mental or physical illness represents the social causation argument. So somebody who's in a low social class, for example, could be economically deprived, right? Have low finances. They could have low levels of education. There are high rates of unemployment. There might be a lack of basic needs or housing, and they might be food or water insecure, meaning that they have difficulty accessing healthy food or clean drinking water. Each of those things could lead to risk factors like reduced access to social capital, which was discussed in your textbook, could lead to malnutrition, could lead to social exclusion, meaning exclusion from social circles because of somebody's lower social class, could lead to higher levels of stress, and risks to childbearing. Each of those risk factors then feeds into mental or physical illness. High prevalence of illness among low social class, higher levels of severity among those in a low social class, and also a lack of psychological or medical care. So that's the social causation argument, that being in a low social class reduces access to a number of resources and puts you at risk for a number of different risk factors, which then feeds into health. The social drift argument is the opposite. That argument is that being mentally or physically ill contributes to a lower social class by increasing a person's health expenses, increasing their likelihood of being unemployed, or reducing their productivity. So, focusing first on the social drift hypothesis, the argument here is that poor health causes one to drift downward into a lower social class. This hypothesis is actually not very well supported by the evidence. So it's true for some people, right? It is true that there are cases where people have illnesses that take them away from their jobs, contribute to unemployment, in some cases even may lead to homelessness. However, these cases are much fewer and less frequent than cases where the opposite is happening, where people in low social positions have a lack of access to resources. So the larger pattern that research has uncovered, and in particular longitudinal research, where they're following people over time, much of that longitudinal research is consistently finding that the drift hypothesis, the idea that people who are ill would then become less advantaged and fall lower on the socioeconomic ladder, that is much, much less frequent than the social causation argument. So rather than this idea of a social drift downwards, the research much more strongly points to this idea of social causation. Social causation theories argue that being in a lower social class is what leads to poorer health outcomes, not the other way around. So if we focus first on fundamental cause theory, this theory argues that people with greater access to resources and power are better able to protect their health, okay? And what's really key about the fundamental cause argument and what Link and Phelan discuss specifically in their article is that the causes that they discuss, and they focus in particular on socioeconomic status. Their argument is that SES, socioeconomic status, is a fundamental cause because it remains as an effect on health even when you take out the intervening links. So take a look at this graphic that I've put together. Socioeconomic status on the left contributes to several different risk factors, which are all in pink. So people on the lower end of the socioeconomic ladder might be exposed to less sanitary conditions. This was certainly true in the beginning of the 19th century, so 1800s, early 1900s. This was definitely true. Increased presence of unsanitary conditions. People at the lower levels of socioeconomic status are also may have less access to immunization. Again, something that might not be true now as much as then, but certainly is true, especially when you think about access to healthcare. They are much more likely to be exposed to lead in the paint in their houses, in the water that they drink, and lead has really severe impacts on psychological and brain development, especially among young kids. Socioeconomic status is related to smoking and diet, both of which we would consider to be health behaviors, and yet are much more prevalent. Smoking and what we might call a poor diet or an unhealthy diet are much more prevalent among the lower social classes than the upper social classes. So what fundamental cause theory argues is that even though we got rid of a lot of the issues around sanitation, we've improved sanitation as a society quite a bit, we've improved access to immunization quite a bit, even when you get rid of these intervening links between SES and health, other things pop up that connect SES to health. And so what they argue is that when you see some of these links get solved, or these problems get solved, and then new links pop up, that shows us that the upstream cause, SES, is a fundamental cause of health. It's fundamental because it's always going to be there. It's always going to find a new way to affect our health. So that's fundamental cause theory. A related theory, also a social causation theory, is what we would call cumulative inequality theory. Okay, so this theory also argues that being in a low social class leads to poorer health outcomes. But this theory does not only focus on access to resources. Cumulative inequality theory is also sometimes called cumulative disadvantage theory because it focuses on the way that disadvantage accumulates over a person's lifetime. So cumulative inequality theory argues that inequality causes health problems that accumulate over a lifetime. Some of this is what fundamental cause theory discusses, right? Access to health insurance coverage, access to safe neighborhoods, those are resources, but also other health-related factors like health literacy, knowing what is healthy and what's not, and being able to act on that. Being able to trust your doctor. Not having as much stress in your life as other people have. And so this figure here that I've included shows how life expectancy, right, the average number of years you're expected to live, or a group of people is expected to live. In this case, we have two different people. The number of years that each of these people is expected to live when we consider all of the advantages and disadvantages that these people have had from birth until death. For patient 1, it looks like they have accumulated advantages over their life course. They have education, they have health insurance coverage and access to health care, they are health literate, and they trust their doctors. Patient 2, however, looks like they had poor nutrition at a young age and obesity at a young age. As they grew older, they had limited employment opportunities, limited income. Their neighborhood resources were lacking. They may have lived in an unsafe neighborhood. They may have had more life stress as a result of that. And they may also have received disparate health care, which means that their care may not have been of the same high quality that patient one's care has been. And so you can see that over time, life expectancy, that their health in general diverges. The two trajectories grow further and further apart as they age, and that the patient one's lifespan is 4.4 years longer than patient 2. Life expectancy is actually a really common outcome for health that we study. And there's a lot of research to show that there are pretty substantial differences in life expectancy when you look by social class, when you look by race, ethnicity, when you look by gender. Essentially, any group that is disadvantaged in our society tends to have a lower life expectancy than people in groups who have social advantages. So those are the 3 theories that were discussed. I'll use maternal and infant health as an example to illustrate this idea of weathering. So you read an article from NPR where they talk about a lot of health disparities for moms and babies, particularly between African Americans and other groups. So you see that there's a 60% higher rate of preterm births, right? Babies who are born too early among African Americans compared to whites. And you also see that among African Americans, there's a 230% higher rate of infant mortality, meaning babies who die within the first year of life. Okay. And a sociologist named Arlene Geronimus has been working on this issue. Her research has been on this issue since the early 1990s. And in 1992, she wrote a pretty important paper about the weather, what she calls the weathering effect. This idea of weathering is the bodily wear and tear that results from exposure to stress. So her work really combines the fundamental cause theory and the cumulative inequality theory, because she talks a lot about the stress that results from a lack of access to resources, but she also talks about how that stress accumulates over a woman's life course. So the stress that women in particular, and this doesn't just apply to women, but in this case, her research is focusing particularly on minority women. Some of the stressors they encounter include raising children, caring for elders, working and providing for their families, oftentimes as the sole provider of the household. They endure material hardship, and they also endure oftentimes gender and race discrimination. All of these stressors have an effect on our bodies. And I've posted a video in the extra resources section of this module for you to get a sense of how stress affects our brains. And there's lots of research out there to show what the physiological impact of stress is. But stress, especially when we experience it on a consistent level every day, has real negative consequences for how our bodies function. This bodily wear and tear is what Arlene Geronimus referred to as weathering, and she saw this particularly acutely among African American women. This weathering then led to poorer health outcomes for these women. It shortened their lifespan, it increased their blood pressure, and then because these women were then having children with bodies that were less healthy, it contributed to poor outcomes for them as they were giving birth. So they were more likely to pass away during birth, and also poorer outcomes for their children in terms of preterm births, low birth weight, and infant mortality. Preterm births and low birth weight are also predictors of health problems for those children as they grow older. So you can see that weathering is potentially affecting the next generation and can have intergenerational effects. That is what is meant by the phrase inequality gets under the skin. Inequality that is experienced by these particular women invades their bodies and affects the birthing process, which is just crazy. So just a couple of notes on these theories. I think the social causation theories can really help us understand the relationship between race, ethnicity, and health, and also between gender and health, because race and gender are both highly correlated with socioeconomic status, and they both have an influence on our access to resources and the advantages and disadvantages that we accumulate as we move through our lives. Link and Phelan don't talk too much about race and gender. They really focus on socioeconomic status, but they do say that race and gender could also be fundamental causes of health because of the relationship they have to the access that we have to resources. So we could use theories of social causation to help us understand health and race and gender. But we really cannot and should not use the social drift hypothesis to study these relationships, because think about it. The social drift hypothesis is really arguing that poor health contributes to lower social status. That makes sense in the case of social class, even though that's not the main contributor to the relationship between health and social class, but it does make sense because your social class can change and does change throughout your life. But health is not going to lead someone's race or ethnicity to change. It's not going to lead their sex or gender to change in most cases. So the social drift hypothesis is really not appropriate when looking at the relationship between health and race or health and gender, but social causation theories can be used to understand those relationships. That's all for week 2 and this week's discussion of the social distribution of health and illness.